Prior to the year 2011, South Sudan was grouped among 40 countries with the highest maternal mortality rate in the world. Only 0.6% of all women deliveries had access to comprehensive emergency obstetrics and neonatal services. Most hospitals were not equipped to receive and treat women with obstetric complications. There was lack of skilled human resources, modernized infrastructure, laboratory and diagnostic capacity, as well as blood banks.
Even during the night hours, there is no light. Before, we are working without light. You can use your phone to see the person, to deliver the mother with the phone. After deliver, no water for washing hand, no soap to wash your hand.
They conduct operations without monitors. Sometimes they don't know the level of oxygen was or when. Where has it reached? It might have dropped below the required one. And people continue that the patient is under anesthesia, while he has passed away already.
In 2011, the World Health Organization, in collaboration with South Sudan's National Ministry of Health, set maternal and neonatal health services as a priority. WHO then launched a 5-year project to support emergency obstetrics and neonatal care running through to 2017. The project was funded by the Canadian government.
Between 2011 and 2017, WHO, with support from the government of Canada, embarked on a very ambitious plan of constructing 6 maternal complexes in this country. Together with the Ministry of Health and the government of Canada, this construction has been completed, and it was eventually handed over to the ministry at the end of 2017. So during this period, when these gynecologists were undergoing training 3 years in the neighboring country, WHO brought in specialists to cover gaps. And while they were undergoing this specialized training, these other specialists that were brought in were able to provide services to more than 180,000 beneficiaries. WHO supported this group and also brought in some midwives that supported normal deliveries of about 49,000. And through the obstetric emergency operation, WHO was able to save 38,000 women that could have actually had either complication or died. These 6 maternal complexes are some of the few most visible centers or constructions that are giving visibility to this country. And from the time this country became independent in 2011, these are some of the few projects that you can look back and say a lot has been achieved. And I would also like to congratulate the Minister, Honorable Riagai, for the commitment he has shown by standing beside the donors and WHO and supervising the construction until the whole project was handed over to him on behalf of the government of South Sudan.
Canada has worked with the World Health Organization to set up the first comprehensive emergency and obstetric care project to help reduce deaths related to pregnancy and childbirth.
It has been a long-standing priority of our government to improve health infrastructure and services across South Sudan.
It is a great contribution to humanity by the Canadian government.
WHO began the project in Bor, Jonglei State, then rolled it out to 6 other state capitals in Kwajok, Wau, Yambio, Torit, and Awil. When war broke out in South Sudan in 2013, the Malakal project was halted. The facilities boast of modernized maternity wings with state-of-the-art health equipment. Apart from equipping the facilities, WHO developed the capacity for local staff who were awarded training fellowships in obstetrics and gynecology. 6 are now back and have helped more than 150 high-risk mothers with obstetric complications to have successful and safe births. The entire team is now able to deliver comprehensive emergency obstetric and neonatal care services.
We have introduced what they call continuing professional development, CPD, to update the knowledge of staff, because medicine is dynamic. We have to keep ourselves abreast of the new interventions, the new research-based interventions that help mothers and their newborn babies.
All what we have got the knowledge from here, when we go back, I think I will educate some of my midwife to reduce maternal death.
WHO also brought in international doctors to train local doctors and nurses on the job. It deployed technical officers and midwives to continue to support capacity development of the local staff through mentorship in obstetrics and neonatal care and hospital management.
They are now able to do things related to maternal health perfectly, as you have seen the ward and even in this delivery ward. So we are actually trying to manage the case professionally as we came in, and we were able to train other people, and we continue training them.
Right now we have one attached to our teaching hostel who is working hand in hand to make delivery safe, and we are happy of her services.
Some of these local staff were absorbed by WHO and posted to the various centers.
I'm an obstetrician and a gynecologist hired by WHO in the Obstetric State Hospital to improve the quality and availability of services, focusing on emergency, comprehensive emergency obstetric care and neonatal care services in Obstetric State Hospital.
The first time when I came, for the first 4 months, they were the people who assist me to be here. And they were the people who conduct a first cesarean section in this hospital.
WHO provided tons of drug consignments to these hospitals in order to ensure their timely availability for the emergency services. This has formed an integral part of the supply chain. It also provided support to referral services by providing fuel for ambulances. Over the 5 years of the project, WHO has reached 180,000 mothers and newborn beneficiaries in the 6 targeted states, reducing maternal morbidity in South Sudan.
What made all this possible was probably the political will and the ownership. Of course, there was varying degree, depending on the states, there was varying degree of ownership. Some states very readily owned the maternity waiting home and the people that we trained and everything. They were quick to absorb and own it, but some took a bit of time. So like I can say, for example, the moment we had opened the maternity the maternity theater, immediately the medical director went in, took over and started running it by himself. It was constant mentoring and constant hand-holding that went on. Now, because of the varying skill mix, which was not, very good, there were some that were traditional birth attendants, some didn't know how to speak English. So there was a lot of things that we had to do. So, we needed this specialist care, but we needed also to do this hand-holding and constant supervision. So this was one of the things. The next point was that we had to do a lot of monitoring and supervision. As we were working and delivering services, we had to always think on our feet. We had to keep thinking of ways of what next, how to do. So what worked in Jonglei probably didn't work in Yambi, or what worked in Yambi didn't work somewhere else. So we had to keep evaluating, constantly evaluating and seeing what works next, you know.
We need the WHO to continue with these activities. We need, even though if they have to at least to extend to another period, so that the effort that they have done to be cemented properly.
WHO would like to thank the government of Canada for all this big generosity they have shown to the people of South Sudan by standing with the people of South Sudan, a country that has one of the worst maternal and child mortality. And I would really like to say thank you so much for the people of Canada.